Good morning. Uh, Thank you very much for inviting me to present at this conference. It is a privilege and honor, and I hope that next time I can be there in person in the beautiful city of Moscow and meet all of you people. So I'm going to be speaking today on Cholangiocarcinoma and other bile duct tumors. And the topics that I will be covering today include the von Meinberg complex or biliary hamartoma, bile duct adenoma, cholangiocarcinoma, the large duct type and the small duct type or types 1 and 2, biliary intraepithelial neoplasia, and also discuss the differential diagnosis of cholangiocarcinoma, which is basically metastatic adenocarcinoma. Biliary hamartoma or the von Meinberg complex is a benign lesion. It is developmental in origin, and it results from remnants of the ductal plate due to incomplete modeling of these ductal plates. Usually, this lesion is focal. It is present in only one or few portal tracts, although it might be numerous in some diseases, such as the fibropolycystic diseases, including autosomal dominant or autosomal recessive polycystic disease or congenital hepatic fibrosis. Now, biliary hamartoma is an incidental finding in biopsies or resections. It's not something that will cause any symptoms. And in surgical pathology practice, biliary hamartomas are most often seen because they are biopsied during abdominal surgery for cancer, for frozen section or intraoperative diagnosis. So let me show you a case. This is a 75-year-old female undergoing surgery for pancreatic cancer. The surgeon noticed small white lesions on the liver capsule, and he sent one for frozen section or intraoperative diagnosis. So this is the frozen section of the lesion, and what we see are benign ductal structures in irregular shapes. For example, over here, this has a very irregular shape. It's a benign structure. There are some more over here. Some of these are cystically dilated, like over here. So some of them cystically dilated lumina, and they're lined by single or a double layer of flat cuboidal epithelium. Some of these might contain bile. For example, there is bile over here. There is bile in this cystically dilated duct, and there's some bile over here. Now, the permanent section, the formalin-fixed paraffin-embedded tissue, shows this lesion very well. We have irregularly shaped ductal structures. Some of these are cystically dilated, and they are sitting in a fibrous stroma. At a high power, you see that these structures are lined by flattened epithelium, as you see over here, or by a low cuboidal epithelium. So some of this is low cuboidal epithelium, and you see this very dense fibrous stroma. This is an example of a von Meinberg complex that was found incidentally in a resected segment of the liver. And once again, you are seeing irregularly shaped ductal structures, some of which are cystically dilated, like a lot of these, and some of which contain bile. Now, here's a second case of a 70-year-old patient who was undergoing surgery for gastric cancer. The surgeon noticed small white lesions on the surface of the liver, and he sent one for frozen section diagnosis. So this is the lesion that we saw on frozen section, and here we see small ducts lined by a single layer of epithelium in a very dense desmoplastic stroma or a fibrous stroma. And We also see some entrapped portal tracts. So here's the hepatic artery, and here's a bile duct. Now, when we looked at the permanent section, so just going back, this is a Bi-Duct Adenoma, where we have small ducts with open lumina and entrapped portal tracts. So the permanent section, or the formalin fixed paraffin embedded section, shows you the small ducts that are lying in a dense fibrous stroma, and you see multiple entrapped portal tracts. So these are the portal tracts, and here we have the hepatic artery within those tracts. This is another, it is a high power of the same case, where we see the hepatic artery in the center and the bile duct, and this is an entrapped portal tract. This is an incidental bile duct adenoma in a liver that was explanted during transplantation. And you see this very well circumscribed lesion made up of these small ducts, which are sitting adjacent to a portal tract. When we look at high power, we see these very well differentiated ductal structures lined by a single layer of cells. And the nuclei here are very monotonous. There is no pleomorphism or hyperplasia or any mitotic activity. And you see these entrapped structures here with the little hepatic arteriole. So this is an incidental bile duct adenoma. Now, the differences between a bile duct adenoma and biliary hamartoma are that a bile duct adenoma is a benign tumor. A biliary hamartoma is not a tumor, it's a developmental lesion. So the bile duct adenoma is made up of proliferation of bile ducts, whereas a biliary hamartoma, as I said, is a remnant of the embryonic ductal plate. So it's more of a developmental lesion. We have small ducts in a dense fibrous stroma in the bile duct adenoma, whereas in a biliary hamartoma, these are irregularly shaped, cystically dilated ductal structures. Entrapped portal tracts are common in a bile duct adenoma. The biliary hamartoma, however, occurs within a portal tract, and both of these may contain bile. Now, distinguishing between these two lesions is not clinically important, because both are benign and no further action is required. And neither of them causes symptoms. These are incidentally found in liver biopsies or resection specimens, or most often sent for frozen section diagnosis during surgery. So then, moving on to cholangiocarcinoma. This is a tumor arising from bile ducts and derived from cholangiocytes. So cholangiocarcinoma can be classified according to the anatomic location, its macroscopic growth pattern, or the microscopic features. That is what you find in literature. We find that cholangiocarcinomas have been classified in one of these three types, or three ways of classification. So the anatomic classification divides cholangiocarcinomas as intrahepatic cholangiocarcinomas, perihilar cholangiocarcinomas, and distal cholangiocarcinomas. And these two diagrams show you the difference between the two. So the small intrahepatic bile ducts, which are the septal and the intralobular, as well as the area and segmental bile ducts, all these would give rise to intrahepatic cholangiocarcinoma. And you see it shown in red. The septal, the intralobular, and area and segmental ducts give rise to the intrahepatic cholangiocarcinoma. Now, the larger ducts around the hilum, meaning the right hepatic duct, the left hepatic duct, which forms the common hepatic duct, and then you have the cystic duct over here. This area gives rise to the peri-hilar cholangiocarcinomas. And you see that in this diagram, the right and left hepatic duct and the common hepatic duct. And anything that occurs distal to the common hepatic duct, meaning within the common bile duct, is called the distal cholangiocarcinoma. And you see that over here. So these are the three ways we can classify cholangiocarcinomas based on their anatomic location. Now, as far as the growth pattern goes, these cholangiocarcinomas can be classified as mass-forming, peri-ductal, intracystic, or mixed patterns. And this is shown in this diagram. So mass-forming are these very solid lesions that are present usually within the liver in the intrahepatic region, but they can be present elsewhere. And then we have the peri-ductal infiltrating growth pattern of cholangiocarcinoma. So this is the bile duct, and the tumor infiltrates in the wall and goes outside of the wall in a peri-ductal infiltrating pattern. The intraductal growth is when the tumor grows within the lumen of the bile duct. So mass-forming, peri-ductal infiltrating, and intraductal growing cholangiocarcinomas, these are the three macroscopic growth patterns. And I will show you examples from our own practice of various types of cholangiocarcinomas. So this one is a resected segment of the liver, and we see a tumor here, which is very typical of a cholangiocarcinoma. It is whitish, it is solid. There are some cystic areas, but it's mainly a very solid, very firm lesion. So this is an intrahepatic cholangiocarcinoma, and the growth pattern can be accurately classified as being a mass-forming type of a cholangiocarcinoma. Now, this is another tumor. This is at the hilum. So these are large portal components that are present at the hilum of this liver. You see the fat, the hilar fat. These are dilated bile ducts over here, and you see a fleshy polypoid tumor within the lumen of these dilated bile ducts. So this is peri-hilar intraductal cholangiocarcinoma. These fleshy growths that dilate the bile ducts. This is a different example of a peri-hilar cholangiocarcinoma. And what we have here is these large hilar ducts. So here is the bile duct, and you see that the wall of this bile duct is actually quite thickened. It's thickened over here, and then the tumor, and you see this bile duct goes here as well. It branches out over here, and you see that the tumor is growing within the wall of the bile duct all over here, and then it's also going outside the bile duct. So this is a peri-hilar cholangiocarcinoma, and the growth pattern is peri-ductal, meaning it is infiltrating the wall and going outside the wall along the bile duct. This is another peri-hilar cholangiocarcinoma in a peri-ductal growth pattern. It is much more extensive than the previous case we saw. So we have opened the bile duct, you see the lumen, you see that there is tumor even as you look into the lumen. You see that the bile duct wall is thickened because there is tumor growing within the bile duct wall, and here it's sort of branching, and the tumor is going along this branch, and then it's going all along this bile duct. So this is a peri-ductal growth pattern of a peri-hilar cholangiocarcinoma. So those were the macroscopic growth patterns. We saw a mass forming. We saw intraductal or intracystic cholangiocarcinoma, and we saw the peri-ductal pattern of infiltration of a cholangiocarcinoma. Now, as far as the microscopic classification of cholangiocarcinoma goes, there is the large duct type or the type 1 and the small duct type or the type 2. So the large duct type is an adenocarcinoma which may consist of epithelium that shows pancreatobiliary type of differentiation, or there might be intestinal type of epithelium within the cholangiocarcinoma or the gastric foveola. Now, very often in the large duct type of cholangiocarcinoma, there may be associated biliary intraepithelial neoplasia or Bile. And the large duct type, perineural lymphovascular and lymph node metastasis is quite common. So this is an example of a large duct type of cholangiocarcinoma. You see these large glandular structures that are invading into the stroma around this bile duct. And the bile duct epithelium itself is dysplastic. It's got biliary intraepithelial neoplasia. And I'll show you that on a high power. So here there is biliary intraepithelial neoplasia. You see these, the lining of the duct has these micropapillary vascular fronts, and the nuclei themselves are pleomorphic, hyperchromatic. They have lost their polarity. We see this here on a higher power where you see the piling up of the nuclei. You see hyperchromasia and enlargement of the nuclei and a lot of pleomorphism. So here, for example, there's a lot of pleomorphism, very hyperchromatic, multi-layered nuclei. So this is biliary intraepithelial neoplasia. Another example of biliary intraepithelial neoplasia, you see these little micropapillary fronts within the biliary lumen. You see nuclei that are rounded. They have lost their polarity. You see that there is a lot of pleomorphism. Look at some of these cells, very, very pleomorphic. They are enlarged and they are hyperchromatic. So this is biliary intraepithelial neoplasia. Another example of invasive adenocarcinoma. This is the large duct type of adenocarcinoma or cholangiocarcinoma. And we see that the duct, the adjoining duct, has these multi-layered nuclei. They are hyperchromatic, they are enlarged, and they've lost their polarity. So this is, again, biliary intraepithelial neoplasia, giving rise to invasive carcinoma. Now, as I said, the epithelium of the cholangiocarcinoma may have different types of morphologies. So here we have the intestinal type of epithelium. And what we're seeing here is the brush border. So these are intestinal absorptive type cells, and you can clearly see the brush border. And the other thing that you see are the goblet cells. So goblet cells, absorptive cells in intestinal type of cholangiocarcinoma. This is an example of foveolar epithelium, gastric foveolar epithelium in cholangiocarcinoma. And this is recognizable to all of you, I'm sure, because you have abundant apical mucin over here, for example, and these small nuclei sitting at the base of these cells, very much like what we see in the gastric foveola. Now, this is a very poorly differentiated cholangiocarcinoma. So we have some gland formation here, but the rest of it is really single cells, highly pleomorphic, very hyperchromatic, that are infiltrating the wall of this bile duct. Very often, these patients present with biliary obstruction and jaundice, and they get stented. So if a stent is put into this bile duct, this is the lumen, you see a stent has been put in, then very often you see that the lumen, that the epithelium lining the bile duct is denuded. And so here we have denuded bile duct epithelium and an invasive, poorly differentiated cholangiocarcinoma. Perineural invasion is very frequent and very prominent in large duct cholangiocarcinomas. And you see these two glands that are within this nerve. So here is the nerve tissue, the nerve bundles, and here you have glands that have infiltrated into this nerve, so perineural invasion. Now, what is biliary intraepithelial neoplasia? It is a flat pre-malignant lesion of bile ducts. It is a field change, so there are multiple foci within the bile ducts. It is a precursor lesion of cholangiocarcinoma. And the risk factors for Bile are hepatolithiasis or stones within the bile duct, PSC, primary sclerosing cholangitis, and chronic liver fluke infections as they occur in the Far East, for example, in Thailand, where cholangiocarcinoma is very, very common, in Vietnam, Laos, and China. And I showed you the microscopic features. There is nuclear multilayering, pleomorphism, hyperchromasia, and loss of polarity. It might be flat lesions or micropapillary projections into the duct lumen. And we grade Bile either in a three-tier system as low, intermediate, or high-grade Bile, or Bile 1, 2, and 3, or in a two-tier system as low or high-grade Bile. Now, this is a cholangiocarcinoma that is made up of these very well differentiated ductal structures that are lying in this very, very hyalinized stroma. And very, very characteristically, they have this anastomosing pattern, anastomosing architecture. This is the small duct cholangiocarcinoma or type 2 cholangiocarcinoma. It is a very distinctive lesion. It is made up of the very well differentiated anastomosing ductules in a desmoplastic stroma. Also referred to as cholangiocellular carcinoma. Usually it is found as an intrahepatic lesion, not so much as a distal or a perihilar lesion. It is usually mass forming, so it doesn't grow in a peri-ductile or intraductal pattern. And it is not associated with a precursor lesion of Bile. And this is just a high power view to show you the type 2 small duct type of cholangiocarcinoma. These very well differentiated ductules with this anastomosing pattern in this very, very hyalinized stroma. So the differences between the small duct type and the usual type or the large duct type of cholangiocarcinoma is that small duct type is usually intrahepatic and occurs in the peripheral liver, whereas the large duct type may be perihilar, distal, or intrahepatic. It could occur anywhere. Small duct type is associated with chronic liver diseases with advanced fibrosis, such as chronic viral hepatitis or steatohepatitis. The large duct type of cholangiocarcinoma occurs with chronic biliary diseases, such as primary sclerosing cholangitis, hepatolithiasis, or fluke infections. There is no biliary intraepithelial neoplasia association with the small duct type, but Bile is usually present, and it is a precursor lesion of the large duct type of cholangiocarcinoma. Small duct type is usually mass forming, whereas the large duct type can be mass forming, it could be peri-ductile, it could be intraductal. The microscopic pattern is extremely distinctive for the small duct type, well differentiated tubules with anastomosing glands. Whereas the large duct type are large glands with foveolar, pancreatobiliary, or intestinal epithelium with or without mucin production. There is no perineural invasion in the small duct type of cholangiocarcinoma, and lymphovascular lymph node invasion is very rare. Whereas in the cholangiocarcinoma type 1, perineural invasion is very common and lymphovascular lymph node invasion is commonly seen. The small duct type of cholangiocarcinoma shows pushing tumor borders, whereas the large type has infiltrative tumor borders. The small duct type is typically positive for CD56 or NCAM, whereas the large duct type is not positive for CD56, but it is positive for S100 and TFF3, which is the trefoil factor 3. The small duct type, this is a mistake. The small duct type has mutations of IDH1 and IDH2, whereas the usual duct type has mutations of KRAS or the fibroblast growth factor receptor 2 translocations. So this is the large duct type, and this is small duct type. I'm sorry, I made a mistake in this table. And finally, what is the differential diagnosis of cholangiocarcinoma? Well, it's really metastatic adenocarcinoma. That's the main differential. Now, if the carcinoma comes from the breast, we have a nice IHC to differentiate between the two, because GATA3 is usually positive in breast. That's what we like to use. For lung metastasis, TTF1 and NAPSIN-A are usually positive. Colon has a distinctive morphologic appearance, but if we want to do IHC, we can do CK20 or SAT-B2, which is positive in colon. Now, the problem arises if you have metastasis from the upper gastrointestinal tract, like the esophagus, the stomach, and the pancreas, because both of these share immunohistochemical markers with cholangiocarcinoma, and there is no immunohistochemical stain to differentiate metastasis from the upper gastrointestinal tract and pancreatic adenocarcinomas from cholangiocarcinomas, because cholangiocarcinomas, pancreatic adenocarcinomas, as well as esophageal and gastric cancers can be positive for CK7. They are all positive for CK7. They can be positive for CK19. Pancreas is positive for CK19, so is cholangiocarcinoma. And all of them may or may not be positive for CDX2. So for differentiation of these malignancies, we require clinical and imaging information. So this is my last slide. I thank you all very much for the invitation, for being here to listen to my talk. And I fervently hope that very soon we will be done with the pandemic, with COVID, and we will be able to see each other in person once again. Thank you very much.